It's really a pleasure to be here again. Andy and Eric have already talked about how special this conference is, and I've had colleagues that there's a conference going on in Toronto this week, and looking at our agenda here and saying, "Geez, I wish I was in Turkey instead." So it really is a pleasure to be here. It's an interesting topic that I've sort of picked here. It's been something that's been on my mind for the last year or so, and it's just the idea of measurement-based care, and I'm really curious in the discussion. Certainly with our Turkish colleagues and other international colleagues in terms of how big the topic is in your country, whether it ebbs and flows. I know it's been around for a very long time. And I'll set it up, we're going to talk a little bit about what measurement-based care is, how, some of the evidence, whether or not it's helpful or not, and some of the challenges of actually introducing measurement-based care into a system, into a health system. I come from the Canadian Armed Forces, which isn't quite as big as some of the militaries, but it really is its own health system in Canada, unique, where there's 17 clinics across the country that provide ambulatory care that includes mental health, and so that's really part of our program. So where this sort of started, if I go back to my former life as the chief of psychiatry, so 2006, 2007, we were fighting a war in Afghanistan, and I was a psychiatrist there twice at the Royal 3 Hospital, the large hospital. And about 10 years ago, let's say 2014, 2015, the Afghanistan conflict was winding down. So, the combat fighting had stopped a couple of years ago. Most of our countries were pulling our troops out. A few countries, small forces stayed. And we're discussing the care that we provided in theater. And in theater, meaning the Americans call it downrange, the soldiers that are deployed, they had mental health problems there. And really, it wasn't like practicing evidence-based medicine, clinical practice guidelines. You thought about it, but you were very creative based on what was going on, the history, what the situation was, what the soldier, was actually the role of that person at that time. And there was really no agreement. There was no consensus on the treatment in theater. We talk about, practice guidelines. Canada and the US, we would initiate care while somebody was in theater. We might start them on an antidepressant if we can keep them, within sort of the fence, within the base for a few weeks, and sort of see what happens. The soldiers didn't want to go home. Their leaders didn't want them to go home. They wanted to finish their mission. That was a really important part of the war. We wanted to improve functional improvement, and if we could preserve the operational readiness and they were fit to do some, even if it was a secondary role, then we tried to maintain that. Other countries, not to pick on them, but the UK, the Czech Republic, if they felt somebody had mental health difficulties, they would evacuate them. They would send them back home to initiate. Not that one's right, one's wrong, they're different, but just the idea of there wasn't sort of a consensus guideline that we could follow. We took losses, Canada took many losses, and it just looks at this and kind of makes me think of, we did get numb to it at some point, the frequency in which they occurred, but again, if one of the interesting things is when you look at sort of the faces of the people, when sort of saying goodbye to a sort of a fallen colleague, there is sort of that loss and grief that sort of hits, whether or not there's PTSD. We saw mental illness in theater, and one thing that, that I learned when I went there was that, everybody thinks, oh, you're going to go there, all you're going to see is PTSD. But if you understand sort of population health, people could have a pre-existing illness. They could know about the illness or not know about it. It could emerge while people are deployed. There could be an emergence of a new disorder just because they're in theater, they're at a certain age that are risk to develop a disorder. This may be the sleep deprivation and the stress may have sort of bipolar disorder come out, a manic episode for the first time, which we noticed things like that. And when you've got sort of 30,000 troops from different countries and you're stressing them and sleep depriving them. So again, that likelihood. Trauma-specific presentations, combat stress reaction, not a diagnosis, but acute stress disorder and PTSD. And we'd often see those in waves. We'd see those sort of after, an IED, an explosion, mass casualty. A few days later, you'd see the emergence of some of the more trauma-related ones. And, you're running a mental health clinic. There's psychosocial issues, marital strife, children. The double-edged idea of having connections with your home country, having the ability to phone home and text and WhatsApp. You start to find out if your kid's skipping school and things like that. So we sometimes did We did marriage counseling sort of from Edmonton and from Kandahar sometimes with the social workers sitting there. So all of these kind of illnesses are possible in theater. And so really it was a general psychiatry kind of practice with social working, with nursing, and trying to do sort of the best that we can. When you looked at in the deployment and you started to actually sort of do a survey while in theater, again, about 8% of people sort of had a mental health problem in general while they were in theater, a mix between trauma and sort of the other general mental health kind of difficulties. But we did realize afterwards, after the mission, when we started to look at sort of the impact of this war, unlike, just like other wars from World War I, World War II, we found that there was an impact. So what we've done here is looking at sort of the location people were in. Camp Mirage was sort of our secret camp in the UAE, not a secret anymore. The Gulf would be our ships. You could be in Kabul, people have multiple, and Kandahar. So Kandahar is where the most fighting was. And it's so the lower rank and the army were people that had it most, same as with all of our allies. And in Kandahar, there was more of the robust fighting against the Taliban. So again, more likelihood of having sort of mental health illnesses, including PTSD. So again, going back to 10 years ago, a little bit of background. So you're back. And we have our lessons learned from previous wars and our history. We're going to have a wave of veterans that are going to be ill. PTSD ranges from 5% to 30%, really depending on who you're surveying. If you're on a ship, it's still not zero. But if you're in sort of a battle group fighting with the soldiers, could be up to about 30% PTSD rate when we measured a year, 2 years out. So with these veterans. Also, we realized by this point, by 2015, I think most of us knew by 2005, that many of the evidence-based treatments that we have, that we deploy, that we use with with sort of all of our zeal, most patients still have a diagnosis of PTSD after they're finished. So, the EMDRs and the cognitive processing therapy, the prolonged exposure, they tend to not respond quite often. We also know that treatment is hard. Treatment is very hard for the patients. There's a high dropout rate because asking people to revisit the worst things in their life, people often drop out as well. So the wars have a lasting impact. We realized that many, many years ago, and we sort of anticipated that sort of as we go along. So in short, this is a setup to sort of, what do we do now? So what do we do if we were 10 years ago? Eric's going to have the fun talk. He's going to talk about what's coming next, our new therapies and promising therapies, novel therapies. So yes, so we can start to think about the other newer therapies. There's also a really exciting, interventional psychiatry. That's a focus for lots of us, which, ketamine, neuromodulation, there's that piece. There's psychedelic-assisted psychotherapy, and again, emerging, promising, signal, not quite there yet. And then, of course, digital health, the equity, and the efficiency that it provides. Our previous speaker gave us a fantastic talk. And then the other thing that we thought about is just measurement-based care, which really is, the idea is, could we provide the existing treatments that are there and maybe provide them a little bit better, with a little bit more efficiency, a little bit more rigor, and would that help us in sort of, in the meantime, while we're waiting for all these exciting therapies, would that help us more? So just a couple of definitions, and I think this is something that we've learned over the years, is that, measurement-based care is routine, systematic use of validated measures, such as patient-reported symptom rating scales, before or during each clinical encounter to inform decision-making about treatment. That's from the Ontario Hospital Association definition. The American Psychological Association, similar definition, evidence-based practice of using systematic and routine assessments of patient perspective through patient-reported progress and outcomes such as symptoms, and throughout the course to inform treatment and to engage patients in their treatments. And I think one of the things that'll come out as we speak about this is lots of people do measurement, lots of people measure outcomes, lots of people do questionnaires when they first see the patient and when they leave. And so measurement is the piece. It's the based care part that I think falls apart in lots of places. Like, are you looking at the results regularly at every session? Are you sharing those results with your patients? Are you making decisions together? I think that's going to be one of the themes. And one of the problems when we research and we look at the literature in this area is that there are so many different terms that people use. And I think Anil did a good point of how in the digital health space there's so many different terms. It's very similar here. Some people call it routine outcome monitoring, some call it progress monitoring, clinical client feedback, and you can sort of see the other terms. And so the evidence-based practice of what I'm calling measurement-based care, there's at least 16 different ways in which the literature, refers to it in 17 different countries. So really trying to scope it and understand how other people are doing it is going to take some translation. And it's difficult to assess the efficacy across different studies when you don't really know are they doing it the exact same way, are they calling it. So there's challenges in terms of fidelity, flexibility, and implementation. Now, when you look at the potential benefits and the evidence, one of the things is that for the patient's perspective, the hope is that there's active engagement instead of passively going in and saying, you're the doctor, do whatever doctoring there is to me. In some ways, the patients now become aware of what the goals of treatment are and what are we looking at every day. We're looking at my sleep, my appetite, my engagement with my family, those types of things. So perhaps they're going to recognize relapse earlier. So there is some suggestion of that. For a clinician, it's always the key is it doesn't substitute for clinical judgment, but it can guide people, especially if there is, unlike the war zone kind of environment, if there are clinical practice guidelines that are consensus-based and agreed upon, maybe it helps us to move from one to the other. So as Eric's going to talk about the newer treatments, maybe this will help us to kind of reach the conclusion that maybe it's time to try something different than what we've been doing for the next while. And then at system level, the idea of surveillance, the idea of outcomes, identify gaps and opportunities for training. And to Eric's point earlier, the question about digital health and trust, the system level trust comes up with clinicians, and I'll talk a little bit about that in terms of a barrier. So part of the rationale for it is there's a lot of literature and quite a lot of it recently, in the absence of measurement-based care, clinicians may struggle to identify patients who are at higher risk for non-response or deterioration in functioning. And there really is a tendency for clinicians to overestimate how well their patients are doing. There's a natural kind of thing. Canadians are kind of interesting. The most depressed person comes in, how you doing? Fine. I mean, that's what our patients say, right? It's just a Canadian kind of way of communicating. So there is this idea of overestimating how our patients are doing if we're not actually, taking the time to do the measurements. So again, just to reiterate, just the four key elements for our definition: routine administering symptom outcomes or process measure, the practitioner reviews the data, the patient reviews the data, and collaboratively we reevaluate and come up with treatment plans or modifications of treatments along the way. And I think lots of places will do number one, lots of places will do 1 and 2. It's the four that are sort of essential to this. So there is evidence for this, for measurement-based care, specifically in mental health, and we did a review specifically in veterans and military populations as well. So there is, and 51 randomized controlled trials, almost all the trials consistently used measurement-based care, showed significant improved patient outcomes, while the one-time screenings and assessing symptoms infrequently were less effective. So an all-in sort of commitment to the process is the helpful part. And then comparing it to care as usual, treatment as usual, again, there's a decreased cost and lower likelihood of patient deterioration. So it keeps the patients engaged and the care is generally improved. And there's a small effect on symptom reduction, but there's also an effect on reducing dropout rates. So I think the idea of keeping people engaged through the process is also a benefit. So in the military, sort of with this background, with this idea of how do we sort of improve our outcomes, because by that point we had realized that lots of the evidence-based care wasn't giving us the desired effect. Many people were still leaving the military, joining the Veterans Affairs, and in Veterans Affairs they were having similar sort of treatment resistance or lack of response. So we introduced this client reporting outcomes monitoring information system, CHROMUS, around the same time that the Veterans Affairs was doing it in Canada. So we thought maybe if we use the same tool, it'll be a seamless transition as people leave our organization. And again, trying to sort of see, can we get, the other ways we could see outcomes would be, prevention, overcome barriers to care, shorten delay to care. Many of these different kind of things were tried over the years, tracking wait times, getting people in sooner. Better treatments, again, as I mentioned, they weren't there yet. So the idea, again, the consensus was to use the existing treatments more effectively. That was the aim of Chromis. Again, we've talked about, why we picked Chromis, so the idea, there was the evidence. And the other piece is that it's trans-theoretical. So the idea of Chromis, the specific tool that we used, it's not just for doctors that are prescribing medications or therapists that are doing therapy. It can be used, we use the OQ45, which is an overall sort of wellness type of scale, and then added on specific for illnesses. But it basically allows people, different clinicians, different backgrounds to use it. Just very briefly, there's just the point here is Chromis has been used in inpatient settings, mental health settings, all different types of settings. So we felt that it would fit in an outpatient ambulatory care program like ours. And as people are filling it, we'll talk a little bit about how they fill it, but then it'll flag certain concerns with the patients if the suicidality changes, substance users. So the idea, again, is over time, if patients change, they can sort of they'll identify different problems, and that gives you something to discuss next appointment. The idea of some of these sort of measurement-based care programs would be to identify ideally, if people are not following the expected treatment response, whatever that means for the illness that's there. And so in an ideal situation, the ideal situation would be if the patient and clinicians say, hey, doc, I don't want to try antidepressants right now. Why don't we I'd rather just do psychotherapy. And then a few weeks go by and the depression isn't improving. A month goes by, 2 months goes by. You can have a discussion together and say, hey, maybe it's time to start the medication, or the other way around. So that's the ideal. That's the intent that we had, certainly within our groups. Now, the implementation milestones, just to sort of talk about this, we procured it in 2014. They were very unique. So one of the things, Anil, I didn't bring up with you, but just the idea of how difficult it actually is sometimes to bring something digital into government. It wasn't the easiest thing to do in terms of IT security and this, and there's no way they were ready to let us use it on the web. It was hardwired. It was incredibly cumbersome. So as we did our pilot, and really the implementation wasn't great, and we're thankful for the pandemic because they actually allowed us to use an online, a cloud-based system to allow people to fill in their questionnaires at home, because otherwise they'd have to all be lining up to use the same cubicle because everything had to be hardwired. But you could see the usage, and this is something that we realized very quickly, that the uptake of it was actually quite low. This is the completion sort of by the patients, and this is the viewing by the clinicians. Yeah, kind of a reach. If the clinician views it, they discussed it. But the idea was 23, 28, down to about 2% when the pandemic started, and then it went up. And across the country, the clinics varied from 70, 80% of the patients were using it sort of at each appointment, as low as about 5 or 10%. So really, we came together and sort of scratched our heads and say, here we have something that there's a ton of evidence for it, and it's the old cliche in the military, hi, we're here from headquarters, we have a great idea for you, go ahead and do it. So put it in, training, local champions, everything we could think of, but the uptake of it was really, really disappointing. And I'm not going to talk too much about sort of, sort of some of the solutions. We'll go quickly through it because I want to leave a lot of time for Eric. But we did a quick sort of survey to see, what are we doing? Like, how do people like the experience? We interviewed a lot of our clinicians and some of the patients. And the overall response to the survey was quite low, so we'll take that with a grain of salt. But many of the clinicians, had a doubt as to whether it met the needs, the consideration of the patients. So people, despite the education, despite the training, didn't buy into the idea that this could be helpful. There was little staff incentive to facilitate Chromis usage, so the idea of thinking about how much time do we allow for people? And again, it was very cumbersome at the beginning. It meant logging into one system, into another system. And, you had a couple of minutes of time of clinical appointments. People don't like that. There was concern about how Chromis results would be used by clinical leaders. And that was an interesting thing where maybe a little bit naively on my part, we kind of said, hey, it's going to be something that, we're going to see how the team does, and we're going to identify training needs and all this. But of course, people thought, you're going to be looking over my shoulder, you're going to start firing me because my patients aren't getting well compared to everybody else's. So I think there was a piece of that needs to sort of be coming in. That's to Eric's point about trust. You bring in something that people trust it. And then again, so the idea is how do we identify sort of the best ways to sort of identify barriers and things. So the drivers that we felt were there was, the practice-based, evidence that patients, a lot of patients don't show reliable change. At the end of treatment, 10% deteriorate. Treatment dropouts were high, and the fact that the evidence shows that these tools can help. So we had the drivers. The barriers, that a lot of people, 85% of people believe that their clients improved after treatment, even though the research shows they don't. So there was a real gap there between where people see things. The practicalities of the administration were perceived as burdensome and disruptive to practice. So it seemed clunky, not seamless, not the way people are used to doing practice. There was also a concern that it was interesting. There was actually a discrepancy where the patients actually didn't find it to be burdensome in some of the surveys that we did, but clinicians felt their patients found it burdensome. So they were protecting their patients from an added burden. And again, the last point I've made already, the lack of confidence that how the data is going to be used, how the data is going to be used by the leaders. So what we call the advantage of the health system to have this data versus you're going to fire me, you're going to sort of judge me based on how my patients are doing. So just very, very quickly, in terms of, so when we thought about this, and as we've been sort of revisiting this sort of within sort of some of the Canadian systems, the health systems, we've had a lot of discussion at some of our conferences, is just the idea of when we bring something like this, we have to start thinking in terms of, knowledge translation, implementation, science. There's a whole expertise of bringing these things that we may not necessarily have as sort of leaders in healthcare systems, but there certainly are people out there that know this. And so the idea really is to, in knowledge translation, so we've got some science that's there, we've got some evidence, and just to accelerate the capture and the benefits of research for Canadians. So how do we get things out there to benefit more people? And that's from our Canadian Institute of Health Research. And I'll just sort of skip through this one because it's a bit complicated. And just the idea of, dissemination and implementing things in terms of getting it out there, getting people to buy in it, getting people to sort of use it. I think that's the challenge when it comes to the implementation science. And that's for any kind of new innovations. And a couple of us were talking about, the new innovative things that have been around for 20, 30 years still haven't actually reached everyday practice. So there's definitely a challenge in getting things out there. And so the idea really, this isn't unique to our own world. So I'll talk, in the box just briefly, it's the idea of practices that no longer require research. Have we reached things where you've done 30 RCTs and you've done things that no longer require research to demonstrate efficacy and effectiveness as a practical matter? It needs to be known already. And so the idea is, and it's not prohibitively expensive, cost is not an obstacle, but their application in the real world is not what it used to be. So the idea of where do we need it? And so just some other common examples and you could pick anything. You could pick how often is blood work being done in diabetics? How often are all these kinds of things? But we're not very good at this. So beta blockers and aspirin. When I was in medical school way long ago, that was already established as a routine thing after somebody has a heart attack. But it's only 60 and 30% in people in most sort of the North American. You figure it should be 100% because it's not expensive, it's simple and straightforward. Looking at sort of, mosquito netting in Africa and measurement-based care in mental health is about 35%. So something that's really been demonstrated being efficacious, the usage of things. So there's a challenge in getting things out there. And so when we look at sort of the kinds of barriers, the kind of difficulties, I won't go through all of them, but there's a concern about time consuming. So we have to think about sort of which questionnaires to give to people. I know whenever whenever we're doing research studies and everybody wants this questionnaire, I always think about how many hours are we asking patients to do it. So they need to sort of need to think about this. The measures need to be used for, for clinical use, not research use are the ideal ones. So there's sort of difficulties with these. They're also number 6, that MBC is over-systemizing and depersonalizing, so it's not sort of customizable. So there's these problems here. And so when we think about sort of the types of things that we need to have is we need to have, efficient measures that just take a few minutes. They need to be reliable and valid, user-friendly, brief, we've talked about. They need to be clinically meaningful and useful, and clinically relevant to decision-making. So we need to focus on not just asking every question we can think of just because it's interesting to me, sort of scientifically or academically, but is it going to help me? And I think that's part of the key. And I think many times when I hear the patient experience, they sit in the wait. I sat in the waiting room. I did a whole bunch of questionnaires. Took a lot of thought into all of the questionnaires, and I walked in. I handed it to the doctor. The clipboard with all, and the person put the stuff to the side and just started talking. So the message that you're giving them that, we don't really care about these questionnaires, we're just making you do it because it's part of the system. I think that's part of where we can sort of change. So I'm just going to wrap up for a couple of minutes with an example of, now our friend Anne Germain, who couldn't be here, is a colleague who is probably the foremost PTSD and sleep expert in the world. And after leaving academia, kind of say, I could publish another book, another few papers. I want to try to sort of make a difference. She developed this thing called Noctum. So Anne, of course, has a bias in terms of sleep, and she feels sleep is a pillar of health and readiness. And she'll talk about how poor sleep can, impact cardiovascular system, immune system. You can read all of these, and there's risk assessment. When we specifically talk about sort of, the illness that Eric and I have spent a lot of time with, trauma and stress. The idea of insomnia can often lead to an event that can also lead to further insomnia, PTSD, other anxiety disorders, depression, suicidality. So sleep recovery can lead, while insomnia, sleep recovery can lead to resilience and recovery. So insomnia is a specific target, sort of from predisposing to accidents, trauma, and illness, but also sort of when people are ill, so targeting using something like cognitive behavioral therapy for insomnia. Now, when the sleep experts got together, they were one of the very early ones to talk about how they can really use measurement-based care in their approach. And the idea, so it's a tight, sort of nice example of this where, if you had good quality measures and sleep logs and you had it, you can match the treatment at the beginning to really understand the person's specific problems. Are they having nightmare? Are they having sleep latency? Are they having this, and match the specific treatments? You monitor it again by looking at the impact, the adherence to the treatment, progress, and then as you keep getting that continuous feedback, you modify and you maintain it. Now, the reality is that sounds fairly simple, but there, again, to Anil's point earlier, there simply aren't enough people around that have that expertise. So this is where the digital solution for the CBTI, which is COAST, a clinician optimized assistant sleep technology, I think that's what it's called. So it's a scalable, just-in-time digital solution. And the idea, again, is there's a clinician portal and a patient portal. And essentially what the patient does is every morning and night, takes them about 2 minutes, a couple of simple questionnaires, bang, bang, simple. The clinician gets a feedback on sort of immediate real-time feedback. The portal guides them towards the prescription of the next week therapy, whether it's sleep insertion, whether dream insertion, those types of things. And so the idea is this continuous feedback. It's digital. It could be passive as well, but I mean, Andy's going to think about that because we talked about what data you can ask people without it. And what they found when they did it just with wearables, without the questionnaires, there was less patient engagement. The patient they felt kind of likes the idea of feeling somewhat accountable to the clinician still. That connection is still there because the questions that I answered, my clinician's actually looking at it. So the idea of this continuous everyday feedback, then once a week, the algorithm will suggest sort of the next approach, and that's the piece there. So, outcomes, evidence-based, like we talked about, there's lots of apps there without this, but really in terms of sort of Treatment as usual for sleep, which is often medication in sort of the military and veteran population. The effect size of 0.4. Traditional CBTI, which is sort of 1 hour a week for, let's say, 6 weeks, is 0.5. And then using this tool in active duty military and in veterans was slightly higher. So it seems to be quite effective using this tool. So I'll finish with a couple of things. And again, there's a bit of a Western, like duh is if you've got teenagers, if you've got kids, every once in a while, dad will say something stupid and the kids will say duh. And a couple of times, what I realized was, interventional trials. I mean, reading paper is something works 60% of the time, 70% of the time. And then somewhere along the way, I realized that, hey, that's only the people that complete. We're not looking at people that drop out, right? And maybe that's part of why we can never match the clinical trials if 60% of people are supposed to get better because, my patients tend to drop out. So I think the idea of having a tool that's going to keep people engaged in care more is going to sort of maybe optimize the treatment. I think that's the piece. And the other thing that I kind of realized that why in real world we have so much trouble matching is maybe the clinical trial itself is an intervention. Maybe when we're measuring every week and we're doing it, how is your depression going, whether it's medication, it's whatever. So the idea of connecting with the person, asking them, maybe that in itself is an intervention. So maybe that is an element of that when we start to add something like measurement-based care in our clinical practice. The other sort of implications. I mean, as I thought about this, I mean, in Canada it's here in many countries. So we talked about suicide still being a crime in some countries, and in other countries, medical assistance in dying has been legalized and been around for a long time. And in Canada, it's we kicked it down the road for a few years, but it'll probably eventually become a reality where people suffering from intractable mental illness can ask physicians to help them to die. And I think that one of the struggles that we have in our community is that are we making sure that people have had access to all the best possible care, and have we done it? And to some extent, practicing measurement-based care, coming up with a definition of treatment resistance, identifying the next steps such as ketamine or RTMS or psilocybin, whatever it is, maybe it'll help us to get to that point. And we can get some of these things, because how are we going to get to the next level treatments if we're not clearly identifying who is treatment resistant or difficult to treat, whatever our terminology is there. So I think I'm going to stop there, and I think Eric's going to take over and we'll have questions after. Does that make sense, Andy?